nasıl kurulması lazım? Artık bunu kendi iradenizle yorumlamak da size kalan bir şey. Benim anlatmak istediklerim bu kadar. Sormak istediğiniz sorular varsa ya elimden geldiğince yanıtlamaya çalışabilirim. Sıkıldınız herhalde. Peki çok teşekkür ediyorum katılımınız için. Sağ olun.
So, good afternoon. We are starting now. It's a great pleasure to chairing this session with my colleague Anton Chami. And we'll talk about the COVID situation. So, we will have 4 speakers, and the 2 speakers are in the room. The 2 others will be on Zoom. So, it will be a pleasure, and we'll start by Dr. Barbara Hogan. She's the past president of USIM, and she is a very close friend of me, and she will talk about the situation. And I know you are a German, so you will be on time, so I'm very concerned about that, about the new concept in emergency medicine. So please, Barbara.
Thank you very much, Eric and Mr. Chairman. First of all, I would really like to thank Professor Bazakanda and Professor Betchet-Al for the kind invitation here to your wonderful Congress. As well, I would like to thank the organization committee with Emre Tektik and his team. So thank you very much indeed for this. I have the pleasure to tell you something about the future strategy for Europe after COVID and more outpatient care to replace hospital inpatients. And this, of course, will be a challenge for EDs and new types of medical treatment centers. In my view, emergency medicine in Europe has gone through 5 phases of development. And when we start with the phase 1, there were not a real strategy in emergency care. The second phase saw more professionalization, such as a specialty physician for emergency medicine and proper organization of emergency departments. And here is just one example of my department in Hamburg, Germany, and with 60,000 patients a year. We have an efficient interdisciplinary work and high-performance teams as a reality. As in Germany, we don't have the specialty in emergency medicine. We have to really work interdisciplinary and multidisciplinary. In our ED, we have intelligent IT solutions. We work with case management and workflow orientation. And we have a patient-focused organization like First View and Fast Track systems. So the emergency care phase 3 is, and now you will see I have now the CEO position in the hospital, so we are coming that the ED is no longer a cost center, coming to a profit center emergency department, to the interdisciplinary emergency department, to a division ED, hub ED in a big hospital group, for example, to corporate center of excellence emergency department. And this means coming just from budget control and administration to value net management. What means value net management for the emergency departments? If you are the head of the department in a hospital group, for example, there you are the head of probably 4 or more emergency departments, then every emergency department has to fill in the patients to the competence centers of the hospital group. And this means provision of coordinated hospital group network healthcare. And then the emergency departments as corporate center of excellence, really coming from cost center and profit center to competence center inside the networked healthcare holding. The international problem is ever more patients in emergency departments. And here we have a study from Jan Stormans in Belgium, 2017, about the growth of inappropriate use of the ED. And you can see with the blue thing that the non-ED patients are rising up. What is this here? We had another study in Hamburg, Germany, in 10 emergency departments, so that we have 20% of patients in the emergency departments were not in need of emergency care. The situation before COVID was huge numbers of ED patients, many of them misusing the EDs. COVID made big changes. In many countries, there were a very big fall in ED patient numbers, some up to 50%. And I have just some examples in Turkey, for example. In Turkey, the number of patients in some EDs fell by about 50% during Corona. And the question is, did this mean only serious emergency cases came during the lockdown? Or does this mean that in normal times, a lot of emergency patients are not emergencies? In Germany, we have the same picture. Germany has 40% less patients in emergency departments in 2020. And in England, for example, in April 2020, the first full month of lockdown, the number of ED visits was down more than 50% compared to the same month in 2019. Before COVID, we had a lot of studies focused on the core problem: how can we reduce the massive numbers of patients misusing the emergency departments? Were we wrong to think that it is not possible to stop the rising number of emergency patients? Are about 50% of the ED patients at normal times are not emergencies? Do we need a new emergency care concept to deal with this? A new emergency care concept must also be created considering the challenge of the big trend in healthcare reducing numbers of hospitals and hospital beds. And here you see a huge difference in the number of hospital beds in major countries. Germany, for example, has 8.3 hospital beds per 1,000 inhabitants. The hospital beds per capita have fallen in all the OECD countries, except Korea and Turkey, because Turkey seems to have a positive case increasing beds linked to a lower hospitalization rate. And the average length of stay in hospital has also fallen in most OECD countries, potentially indicating efficiency gains. So here you see the number of lengths of stay in days by the OECD. So the question is, if people in a country stay longer in hospital, does it mean they live longer? Life expectancy in a country is not correlated to the number of hospital beds or length of stay in the hospital bed. So the challenge for the emergency care concept phase 4 is not get the patient out of the hospital bed, but do not get a patient in a hospital bed. So using the emergency department as a strategic control instrument to increase or reduce the number of in-hospital patients, use the ED as an out-of-a-bed tool, or use the ED as a get-in-a-bed tool. And I will give you 2 examples, what we did in our hospital. We could use the ED as a strategic control instrument for get-in-a-bed. If a hospital needs patients, the ED can provide them. You all know about these that you cannot find the beds in the hospitals, but they are some. The line in the middle, you see, is the goal of the hospital in patient bed occupancy. The ED on the left massively overachieved. Most other departments underachieved, but they could have achieved if they accepted the ED patients. Here you can see that we have 150 sick in the ED for 1 month, and the others are a little better because they accepted the ED patients. The ED as a strategic control instrument for not in a hospital bed is much easier because we have this exit block everywhere. These graphics show a rising number of ED patients, and we have 38,000 in 2009 and currently about 60,000 emergency patients per year, but reduced the number transferred as inpatient to the hospital. So now we come to the emergency care phase 5, using new care centers with cross-sector boundaries. And I'm talking about the sector outpatient care and the sector inpatient care. But crossing sector boundaries need a transformation away from the silo hospital hierarchy, with their orientation on function plus their hierarchy working like operational islands. And we leave the silo mentality behind towards a process-oriented and patient-centered expert organizations. And what I mean is that outpatient clinic, treatment clinic, EDs, and hospital and aftercare are working together in an integrated healthcare to be a high-performance healthcare organization. And for this, we need some kind of hybrid outpatient clinics for treatment and diagnostics. And this could be like this. We have the treatment clinic, some kind of diagnostic center, where all the basis emergency care for all outpatients are coming. We have specialists there, using by these treatment clinic and using by the hospital. And we have a joint clinical decision unit award for daytime observation of patients, and this could be used by the hospital, by the emergency department. And if patients from the clinical decision unit necessarily have to go to hospital, then they can immediately go there. So at my new clinic in Hamburg, I'm just building such a hybrid thing with general practitioner and specialist physician care, and we're starting this new hybrid emergency care, and we started already in 2019, and just with 6,000 emergency and acute patients, and only 7% transferred to the hospital. As well, we make consultation with telemedicine, live stream for homes for the elderly, that they are not coming for everything and anything to the emergency department. And this means big time savings for ambulances and doctors. This is a new photo of our Elbe Medical Care Center as a regional care campus, and of course it's already published. The next generation of emergency care, and we talked this morning about artificial intelligence, many new possibilities are being developed with digital technology. For example, in Germany, we have a Medibus railway to fill gaps in the healthcare network in rural areas. We have Henry the Dentist. This is a clinic on wheels, a mobile dentist practices. And we have a self-driving medical clinic on demand, which patient can get consulted and diagnosed by video link, get a prescription, or transported to an ED. Visits could be ordered with a mobile app. And in China already, we have the artificial intelligence-powered unstaffed 1-minute clinics in public areas, provide a range of smart medical examination devices, and provide users with one-stop medical and healthcare services, including consultation and medicine. Thank you very much, and teşekkür.
Thank you, Barbara, for this excellent presentation. Do we have any question? Yes, please. Chet.
Yes.
You talk about the new concept of emergency medicine. Let us talk for the future, further concepts. One day, if you become the Ministry of the Health in Germany, what do you want to change in the emergency department? Hopefully you will become.
Yeah, thank you for this question. Immediately implement the specialty in emergency medicine, because now in Germany we have in the emergency department 27 specialties around the clock every day. So we need just one, as you in Turkey. So we are very, very happy to invite you to the USEM Congress to Berlin next year to tell the Germans how to do it in Turkey, how to do it in France, how to do it in Spain, how to do it in Italy and wherever. So this is what I really would do. But the reduction of beds and the reduction of hospitals, even in countries which has so many beds per 1,000 inhabitants, like Germany and Korea and US, for example, they have really to reduce it, because the best countries are Turkey, are Sweden with 2.3 beds per 1,000 patients, 1,000 inhabitants.
No further question? Thank you, Barbara.
Okay, so we move on to our next presentation. For this one, I have the honor of presenting my colleague and senior in the profession, Dr. Eric Revue. He is head of the emergency department of Hôpital de la Riboisière à Paris, and he's co-chair of pre-hospital at USEM.
Hello, it's always an honor, a pleasure to be with you. And we talk a long time, we have a lot of papers about the COVID. So I won't put anyone, no papers, no statistic about the COVID. But just talk about the problem we had with that. I don't have any conflict to declare. Imagine the COVID-19. But not this one. COVID 1999. It happened. It was the Spanish flu. A lot of patients, people were wearing masks, a lot of patients in the department, and the disease is exactly the same, with hundreds of patients who die. What's the main difference? No TV, no internet, no iPhone, no social media. With the same pandemic, they have to face the same disease, but there's nothing at all that's the problem. Historical, from before 1919 to now, we always had to face with the anti-vaccine people that don't trust vaccine for many years. At the beginning, for Jenner to Pasteur, it was really our problem. Why that? Because we just understand a few decades before, that's the mechanism of the vaccination. We didn't know how it works really. So it's hard to explain to the population that need to have the vaccine. It's not natural, the vaccine. Vaccination for people, for kids, you'd have to explain to babies, to the family that they need to use that. And we always have criticism about the anti-science force, a lot of people everywhere since the beginning of the vaccination were against the government, it was politics, against doctors. Maybe you have to know that even Jenner or Pasteur, he had to face because all the population said, maybe you want to put the vaccine because you want to make money with that. So it's the same that happened before. The problem here, regarding to the WHO, doubts about vaccine is one of the top 10 threats that we have in this year. It's because we have a lot of things now. We have made a lot of progress. We are facing. It's still the main problem that we have. And we have the main challenge. We have to vaccinate a lot of people. And 60 million of elderly patients are on high risk to be vaccinated. So we have many problem solving. It's a funny joke. There's a different way. You've got a problem, you have a German, he will fix the problem. No problem. You find a solution very quickly. I don't make a comment about the US. They put in a bomb, they can put in a jail. They solve the problem. In Russia, you have seen how they can fix the problem. I think the worst could be the French. You have the problem, you are fighting, we are always on strike. The problem is we have more problems later. So it's really hard to have that. So tell to a French, you know what, you need to wear a mask. And he says, I don't want a mask, I don't want a mask, I don't want to. It's my freedom, I don't want to. Okay. Maybe we can tell him, you know what, the Germans, the Turkish, the English, they have masks, but you, the French, you don't deserve it. And the French will come and say, okay, that's not normal, I want a mask, me too, I want to wear a mask now. So that's very, very complex to explain to the people that it could be demographic, structural, social, or behavior problem to vaccinate people. There's another thing we are facing. Anti-vaccine is not vaccine hesitancy. We have people that will refuse everything. They don't want the vaccine. You can say anything, they won't have it. And you have some people, maybe they're quite hesitant, that don't trust. If you explain, maybe they will change. Maybe they will have the argument to explain that they could accept the vaccination. It's not hesitancy, it's not activism. We are facing people, they don't trust us. You can do anything, they don't trust us. Our role is to explain to people who trust us that we need to have a vaccine, and vaccination is good to prevent this disease. There are so many determinants for acceptance or refusal of a vaccine. Social, risk perception of disease. I'm safe, I'm healthy. A young guy say, I'm healthy, I don't have any comorbidities. Why do I have to get the vaccine? I don't need to. So mainly the thing we have to explain. It's unsafe. Is it safe? No. We have people that are looking on the media, and even doctors, they say, no, vaccine is not safe. So they need to trust that, and we have to understand here are the main problem we are facing. Politics, yes, it's a big problem because it's very close when you have a campaign with politics. Politicians have a very big role. We don't have any comments about Trump, but we know how he fixed the problem. He didn't, anyway. And it's really a problem that had in their country. They have still the wave in their country because it's more a criticism about the way of Trump managed the disease. The anti-vaccine movement, that's the terrible threat we are facing. This guy on the right on the slide, you know, here are the experts on this really anti-vaccine movement. We have a humorist, singer, psychiatrist, lawyer, senator, candidate, and a blogger. And these people are really more maybe powerful than me if I say you have to take the medication or not. It's terrible. Thanks to the media for that. So they reject vaccination for many reasons, maybe for political reasons, but they don't want to have the vaccine for any reason. They are very strong against that. It's really hard to face these people. Social media. We have 65 million of experts in my country. You know what? They have 65 million of politicians, professor of emergency medicine, professor in epidemiology, a trainer for the football team. They know everything. On the media, they know everything. And the problem is these people are better than you. They know everything. They say, yeah, I have seen my cousin, my grandmother, she's got the COVID, but I know how to treat them. The problem is, due to the social media, all the information is coming with fake information due to the social media. And that's the thing we cannot control. And normally, people, they trust doctors, they trust nurses. And what is the problem? When you have doctors and nurses, they don't trust the vaccination. They don't trust the medication. That's the main problem. When you see these kind of nurses, they say, we don't want the vaccine. It's not safe. People, they trust the nurses. They trust these fake doctors giving this fake information. So it's a growing problem with these people that's with the media, with the social media. You want to trust, and they say a lot of bad story that happen. So the problem you have to deal with this criticism. Information, if you give more and more information, it's not more and more trust in vaccine. Maybe we give a lot and maybe too much information to people. And you have anti-vaccine people, you can say anything, they won't have the vaccine. They don't want to hear anything. So the more way you try to explain to people to have the vaccine, to wear masks, they don't want to. So these very strong people, they don't want to listen to you. Maybe psychiatry could help us. Maybe that's a Dunning-Kruger effect. It's the perception of people. They have the feeling that they are experts. The more stupid they are, maybe the more expert they should be. So they know, I know everything. These people are on the TV and they explain that I am an expert. You know, remember, I have the vaccine, so I can put a spoon here on my arm. Look, I told you, there's a magnet inside the vaccine. These people just show off on the TV because they have a spoon on the arm. So we have a strategy with 3 steps. Identify the technique, identify the topic, and maybe use a key message. Identify the technique. We have a famous video and movie that's it's all the combination of anti-vaccine arguments with all anti-vaccine experts, nurses, doctors, the conspiracy theory, and these people are against that. And that's the way it was really, really bad that happened in France. But they have also other film about the conspiracy theory. They are fake experts, and this kind, well, you can fight any fray. They will trust about this kind of information. Identify the topic, mistrust of and distrust of health authority and healthcare provider. That's a problem. They don't trust us. We have a low threat of disease. That's a problem. They say, I'm not sick. I'm healthy, so maybe I don't need to have the vaccine. And we have to explain that. They have to use, we try to explain that all the patients are in ICU are not vaccinated. We try to explain and say that's fake, it's not true. But we try to explain, we have this patient in our emergency department, in our ICU. So we have to deal with that. Use a very simple key message. If you get vaccinated, you won't have to go to the ICU. That's the only way to explain. I think you can put any papers. I think it's the most simple way to explain to people. So, if it still increases, if they don't understand, mandatory, put the police. It's like when you want to road traffic control, put it seatbelt, don't drink to drive too fast, and we put a policeman. It's exactly the same. Put a mask, wear a mask, get a vaccine, social distancing. If you don't, we'll put the police. And it's always the same, because we always have people, they say, I have never been, I don't drink, I'm fair, but you can have an accident. It's exactly the same to explain. You have to be mandatory. Yes, it's freedom, we lose some freedom, but we have to think on to the others. So it's a 5A model. Maybe it's access. It's a shame that in our country, people, they refuse the vaccine, and they have lots of country, they will love to have the vaccine. So that's a shame we don't have that. Affordability, that's the price. It's not so expensive. Awareness about that. We have many people, they should be that. It's funny, but the Pfizer, you remember, Pfizer just produced Viagra. There's no problem for men. They say, no, I can't take, they don't trust me. I don't need randomized control trial to use if the Viagra works or not. It's not a problem. So this way for acceptance, activation, and activation maybe put the police for these management of the patients. So I see that my friend Bashar Gender is here. And the challenge of we have to face is very easy to remember. So be aware of the disease is 1 to 10 global threats. A, the 5A model. Remember how to deal with that. Social media are useful but dangerous. Authority, health have the most difficult role. Resistant are our bigger challenge. And C, for communication strategy, we have to communicate and define a good one. A, anti-vax and conspiracy theory are very close, so you have to fight with that. Nurses are the most people hard to convince. Disease is not only the COVID. Fake information are worse. Experts are not on the social media. Refusing vaccine is historical. Thank you.
Thank you, Eric, for this presentation. I really liked your slide on the Facebook and Twitter experts. Does anyone have any question to? Please go ahead.
Presentation. I am Dr. Emre from Karabük University. Do you think that is it useful to implement our cultural values when we are dealing this problem? I think about this vaccination hesitancy.
Yeah, I think you fully agree. I think every message should be different from a country to another one, and the culture is very important. I totally agree with you. The thing is, I think globally, people that trust doctors, but the thing is, culture is a very important way to explain. You're right. Thank you.
Sorry, do we have any other question?
Thank you. Hello, so now we are online with the Zoom, and we have the privilege to have Professor Abdel Balou. He was past president of USEM, and he couldn't come in Turkey. You know that the guy, he loved to dance, and every gala dance. I think he is very and happy to be not to be here. Abdel, can you hear us? Abdel? Professor Belou? Is Abdel Belou ready?
Hello?
Okay. We can hear you.
Hello?
We have
I'm
the
ready.
slides.
Thank you. Thank you, Eric. Thank you very much, Mr. Chairman, and thank you for the kind words. And yes, I'm very sad not to be with the group, and I would like to thank my friend, brother, Bashar, and also Al-Bisset, and all the team. Very nice team. Assalamu alaikum. You give me a very, very important task to share with you the recent information about the treatment of COVID-19. And you know that it's important to go to scientific evidence when we decide to approve different drugs. I don't have any conflict of interest for this Congress. And the question is, do we have any drug that improve COVID-19 outcome? You know very well that we need a scientific approach about pharmacology and to decide which treatment would be the best. You know that the randomized trial highest evidence for a decision. And you know also that the RCTs are on the top on the clinical studies. But in the top of the top is systematic reviews with meta-analysis. I will show you all data according to the result coming from systematic review and meta-analysis. You know very well the story of this pandemic is it's an enormous impact on all domains of activity in the world, and the world is involved in this extraordinary scientific production to control this pandemic. Is a fantastic race, and the scientific did a good job to get the treatment. I know I will not go, but you know that some people will not have symptoms, but they can transmit the infection to another one. And globally, you can see that the critical patient in the world represent 0.4 of the global active cases. Hopefully, the mortality is close to 2%. More you are sick, more you are in a severe disease, more you have dysregulation of the immune system. And we know also that the first step in the immune system is to develop quickly the response from the immune cells, T lymphocyte, in the beginning, and then activated will produce antibodies against the virus. And the peak of the IgG start at 7 weeks and then decrease unless you get a new infection or, of course, you are vaccinated. We know also is the most important factor, and more you are old, more the risk to go is high, and also the risk to die is high. Hopefully, we are seeing now that the decrease in mortality, okay, and we think that vaccine has a very important role, of course, combined with the protective measures, and also we're seeing a decrease of the cases. All over the world, we are now, we hope, we are now in a plateau. In Asia, Europe, Middle East, not too much, North America, Latin America, and very, very low in Africa. No, we are in a plateau now. Quickly, you know very well this virus now, and it's a complex virus. You know that this virus comes from the bat, the human transmission, and the ACE2 receptor is very important for the entry of the virus. And we know that the spike S protein is the most important protein that will attack the cells in our body, starting in the line. It's an RNA virus, and you have multiple different protein around the membrane. E2 is very high expressed in the intestine, in the kidney, and the testes, and we have also in the heart, and of course in the lung. And the virus will enter through this receptor. It is a very nice picture here. You can see the entry of the virus here, endosome here, and then is of the viral RNA, and then translation, then traduction, and then all the protein of the virus, and then you get a new virus here that will affect other cells. This slide, I show this slide because I want to show you this phase. This is the cytokine storm. I think you know very well this phase. And this phase is responsible of this very severe infection. And all the patients are in ICU. Many cytokines were released from the cells, macrophages, and T lymphocytes. We will talk about this cytokine storm later. And you can see here, severe patient, this cytokine is very highly increased, inducing heart problem and lung problem. Just to show you this slide, because it's very important. This virus, not only this one, but this COVID-19, block the production of interferon family cytokine, this one here. You can see here, this is very important, this cytokine, because this cytokine, interferon, will block the action of the virus by blocking the replication. Keep it in mind because we know that there is a deficiency in toll-like receptor 3, and we found mutation on this production of this cytokine, which explains that patient will be in ICU and unfortunately die. Finally, a group from France, or international group, showed that in people in ICU infected by COVID produce also autoantibodies against type 1 interferon. And you can imagine why those patients had a severe disease and can die in the ICU. Let's go now deeply in the drugs we know so far. You know that chloroquine, you know the story of the chloroquine from one famous professor in France, Didier Raoult, very famous in infectious disease. And this drug, we know that this drug work in vitro, in the lab, and this drug block the viral entry and also have an effect on leflunomide, the tocilizumab is very important. I will tell you more about that, blocking the IL-6 receptor, and also the anakinra, which block the IL-1. We have also the JAK inhibitor, which block the inflammation, and there is some group working on the stem cells, and finally, we can use plasma therapy using antibody to block the virus. I explain to you the action here. You can see chloroquine here. This drug can block the entry by blocking this protein membrane with the receptor of the ACE2. And here, the tocilizumab will block receptor to IL-6. IL-6 is very important in the inflammation induced by the virus. Just to show you this slide, to see how it works with the convalescent plasma, the recovered patient produce different antibodies, and these antibodies can block different antigen in the virus. But you will see that it was not very convincing in 3 hours. This is a very important slide, and now I can give you information here that in the world we had 4,553 trials different drugs. Okay, at the end, 516 trials were not published. We don't have the results. This is very, very important. And this slide shows you only 28% were published in the academics. This is an important information. 1,516 were not reported. And just to show you this sign here, you see that a lot of trials using interferon alpha and lopinavir and ritonavir. And I will show you the results. Okay, chloroquine, hydroxychloroquine, it's clear from the meta-analysis, and you can trust, you can go to the papers, no problem. There is no effect in the viral clearance. There is no effect in the clinical progression. And the conclusion is clear. No effect of hydroxychloroquine in the treatment of COVID-19 infection. And even in the, in vaccines, there is no interest of this drug. It's unfortunate because we love, and not very cheap, but unfortunately, we don't have evidence. The other paper in the Facebook is ivermectin, is an antiparasite drug. The Cochrane library say that there is no effect of this drug in the COVID-19, but we have evidence for that. Remdesivir, you know that we have many problems with the remdesivir, even political problem with the fighting between remdesivir and hydroxychloroquine. This last Cochrane database systematic review in 2021 August confirmed that there is incendiarity on this remdesivir. There is something, but not very high. Now, this is why WHO did not include remdesivir in the list of the drug we can use. Let's go here now. Very important drug, the tocilizumab. It's an anti-IL-6 receptor. You know, IL-6 is an inflammatory cytokine, induces a lot of damage in the cells everywhere in the body. And we have many trials. And this one is a meta-analysis analyzing all the publication. At the end, you see here 24 with 5 RCT. The conclusion is clear. This drug, anti-IL-6 receptor, reduces the risk of mechanical ventilation. Look, maybe there's a decrease of the risk to have a severe or critical manifestation, but there is no really effect on the short-term mortality. Look, we need more RCT to demonstrate that. Okay, the interferon, I show you, block the virus attack and the virus replication. Many people want to study these different drugs. Unfortunately, there is no strong evidence to use this drug in the COVID-19. It's a pity because I think that interferon is very important in the blocking the infection. The IL-6 antagonist, you can block the receptor and you can block the IL-6 by itself, because IL-6 is a very important pro-inflammatory cytokine. And hopefully we found from the meta-analysis an association with a lower mortality. So we can conclude that anti-IL-6 antagonist is good for this infection. I want to finish with these slides to show you the convalescent plasma therapy. You know very well the procedure. We take the blood, then we get the antibody, and then transfuse this antibody to the COVID patient. Unfortunately, there is no evidence to use convalescent plasma therapy in COVID-19 patient. In conclusion, I have three or four. Please give me a few minutes. Maybe I'm late. COVID-19 infection is a multi-systemic disease. This inflammatory response involves innate and adaptive immunity, cells and humoral immunity. The pharmacological approach include the blockade of the virus action and the blockade of the pro-inflammatory cytokines responsible of the cytokine storm. So far, what we know now, we know that the corticosteroid has an effect by blocking the inflammation and immune responses. And RCT shows some interest in the mortality, by degree of mortality, as shown by this famous recovery trial. We have also the anti-JAK and corticosteroid, which improve the PO2 over IO2. The IL-6 antagonist seems to reduce mortality, and the anti-IL-6 receptor decrease the risk of mechanical ventilation. Let me finish. The last big miss is the Living Project, publication +1. This study showed that corticosteroid might reduce the risk of death, serious adverse event, and mechanical ventilation. Also, remdesivir has some effect on serious adverse event. The other drugs, intravenous immunoglobulin, tocilizumab has an effect, bromhexin doesn't work, lopinavir, ritonavir, interferon beta alpha, plasma and colchicine don't have significant effect. That means we need more trials to get more scientific evidence. This is the conclusion here. According to the stage of the infection, stage 1, 2, 3. In the stage 1, we have only the remdesivir, but we don't have too much evidence for these drugs. In the stage 2, we had an effect with corticosteroid, tocilizumab, anti-IL-6 receptor, and the baricitinib, it's an anti-JAK, anti-inflammatory. It looks that it works in this stage. In the late stage, the inflammatory stage, we can keep the same drugs for the convalescent plasma, no evidence for azithromycin, and no evidence for chloroquine. And as Eric said previously, hopefully we have the vaccine, and this is a big evolution in this disease. Of course, I will not go deeply in this topic. It needs a whole presentation. But it's clear that more you are vaccinated, less you have severe patient or critical patient and mortality. But you can see in this map, they need more vaccination. Only 4% of the population of Africa is vaccinated. So we have to act globally, because once we control the infection, if there is one continent not protected, then the risk of the reinfection and the pandemic will be possible. Yes, thank you very much. I was happy to share with you this. I hope the connection was good, and thank you very much.
Thank you, Professor Balou. Do we have any question in the audience? A question about... No? I've got a question for you, Abdel. Can you hear me?
Yeah.
With you show us that all the evolution of the management of and the treatment of this virus, the COVID. What do you think about the progress we have made very quickly to find a cure, but you find a vaccine? What do you think about the next variant that we have, maybe we'll have in the next weeks or month about that? We think we are prepared to manage this kind of disease if we have a variant?
Yeah, Eric, is a good question, and I can tell you that what the scientists did in few months, let's say in 1 year, 1 year and a half, to produce this vaccine. We have different types. But now in the Western, but everywhere in the world, we have this Pfizer vaccine, which is RNA technology. What we know now this is the last paper. I didn't talk because it's not my topic here in this presentation. What we know now, and we had a publication, I think, in the New England or Lancet, they show that that even we have variant, the vaccines still have action, efficiency. Okay, now we had 95% for the previous variant, and now for this one is maybe 65, 70. But in the meantime, they are working to produce vaccine that will be efficient on the variant. Look, I'm very optimistic for the next couple of months or maybe next year. I'm not worried about that, but we need to vaccinate everybody. This is very important. And you tell us that there is a small part of the population in the world that doesn't want the vaccine because of fake news and so and so. But clearly, the vaccine is the only way to prevent the infection and to prevent the critical care patient. No, I am optimistic.
Thank you. We are optimists too.
Dr. Eric, can you say something for Dr. Bellu?
Yeah.
Dr. Bellu, thank you very much for your joining us. Waiting you next time face to face. Thank you for your support. Get well soon, inshallah, soon. But we waiting for you.
Inshallah.
But it isn't possible. All Turkish people say hello to you. Thank you very much.
Thank you very much. I appreciate it. Yeah. Thank you very much. Yeah.
Okay, so for the last session, I'm going to introduce Carlos Garcia Roses, which is the head of the Mexican Society of Emergency Medicine. He's going to talk to us about the current situation in Mexico.
Carlos, can you hear us? Hello, Carlos. You are online. Yeah. Hello. We see you. We put on your microphone. We can hear you. We see you now, Carlos.
Okay, Emra.
Good.
Okay, now you hear me?
Yes.
Okay. Well, first of all, thank you for the invitation for the committee to organize this excellent conference. Thank you, Eric, for presentation and everything. And I only correct, I am the president of the academy, not the society, okay? I don't want to conflict with somebody else. Okay, anyway, we want to talk, next please. We want to talk about what is the situation, but we need to see in real situation that the epidemics always exist and have a potential threat for the humanity. When you, next please, when we see the history about that, we see that the epidemic start and continue producing many deaths in different parts of the world. Next. By April, when it started the recognition in March, in 1 month later, we have 1.5 million of cases in more than 200 countries. Next, please. So it's difficult that now with the all, in the map also confirmed patient that we have in Mexico is, next please. In June, we have 20,000 deaths and we have 200,000 confirmed cases for the pandemic. But what is the effect for the pandemic in country and in different parts? In July, the director of the World Organization said that for several weeks, the number of the report in the Americas has been more than the rest of the world. The pandemic started in China, and then was for Europe, and we have time to prepare. Next, please. And we don't have correctly the situation. The infection starts to continue among the healthcare worker, high in Latin America than the rest of the other parts. Next, please. In Mexico, in 1 day, only report almost 2,000 single days cases for the contagious. Next, please. In July, we have in the world 12 million for infected and 23,000 deaths in Mexico. Next. According with the Mexican Association of Doctors and Nurses, in August, we have 3 times more infected doctors of medical personnel for healthcare than the rest of the world. Next. In September, Mexico alone account for the 45% of all deaths among healthcare workers for 17 countries. Next. So Mexico was one of the worst situation for the health workers. The infection and mortality in the official situation was nurses 40% was infected, physician 26, other type of the health worker is 30%. And the health worker infected 2 developed severe disease, according with this author. Next. In February, we have, according with the World Health Organization, 37 million cases of COVID among healthcare workers. But when you see in 183 countries and represent 36% of the total and the global. And in Mexico, we have 23% of the total healthcare workers was affected. We also suffer the impact of the economy. Next, please, next. We also suffer, the effect for the cancellation of the flights. We suffer for the essential activities suspended, and we suffer the consequence. United States and Europe faced to the crisis and announced tax package for stimulate income and prevent companies going to the bankrupt. Mexico don't. So this is why we lose almost 1 million of jobs, according with the Social Security. Next. In March, the impact of some states is bigger than the other one. For example, in Quintana Roo, because in Quintana Roo we have Cancun, and we lose a lot of tourists, and this affects the economy. Also in Baja, because we have the Cabos and all these tourist places was affected, and the economy suffered the consequence. Next, please. And this is why we lose the gross domestic product between 8.5 to 12% according with the results. But this is the situation. The health budget decreased more than 20% during this period of time. In the last 3 years, with these 6-year terms, we decreased the money. In this slide, you can see, according with the gross domestic invest in healthcare, you see here, the United States, they have 70%. Mexico is the second last one. We have only 2.8%. So in this situation, this is why more than 16 million of Mexicans, they have financial health protection. They don't have it, and this is why they suffer the consequence to go into the healthcare. Next. This is why Mexico is one of the high letalities that we suffer in Latin America. Next, please. In the slide that my colleagues, they show it that the numbers is 2%. In Mexico, we have the lethality between 8% to 9%. This is why in September, Mexico was this is the country with most death for COVID in health professional, more than the United States, Brazil, and United Kingdom. Next. If you are Mexican at that time, the risk of death of health personnel is 4 times more than the United States and 8 times more than the Brazilian guy. Next. In September, because after the holidays, we have the independent days and holidays, one death every 3 minutes. But the next, please. But the other 70% occur in men, and the age of group was between 15 and 40%. More states suffer the consequence, Mexico City, Puebla, and other ones. But the authorities' priority was that the hospitals are not saturated. Also, the cemetery is full, and the funeral can be gave. But who is responsible for the deaths from the pandemic? Somebody needs to be responsible for that. The government all the time say different numbers. The deaths for the COVID will be higher, according with the economists, because sometimes the people outside, they need to come to tell you what's going on, because the government and the politicians, they don't say the truth, they say fake news. The deaths for the COVID would be higher than the official number. Next, please. And this is why the economy start to write some papers. And they said that they have the excess of mortality. They wrote one paper between April and August. This study said that the excess of the deaths at that time, next please, is more than 30,000. When you see in the shadow, in the left side is Mexico City. The shadow, the pink shadow showed the accord with the government, but the excess of mortality is bigger. But not only in Mexico, also in Ecuador, Rio de Janeiro, and Peru, and other countries. Next one. Because sometimes it's the information for the government, another time is this. In this situation, when the Mexico City participated in the study, the COVID deaths, according with the government, deaths is 9,000, but the excess of mortality is 30,000 more than this. Next. And also the impact of the pandemic in the poverty affect the situation for the care. In this study, in these sources, Cenepal, and the UNAM, they wrote that the poverty increased in more than 9 to 10 millions, and the increase more than in the extremist poverty, more than 6 to 10 millions in the poverty. This is why, next please, the consequence for the people go into the hospital is hard. In the other hand, the politician and the government, the National Electoral Institute, approved 38% increase in financial political party. Why? Because they want to be election year. And you know that in the election, next please, in the election, they want to invest a lot of money to produce this. But according with the papers, in the 2020 is the year with the worst contraction since 1930 in Mexico. But what you see in January in 2021, you see the new cases. In 1 month, we have 33,000 deaths. Every day we lose 1,000. When you compare the holidays for the September 16, 19 and 16, and you compare for the Christmas and New Year in January, in September, we, excuse me, what's going on? In September, we have 1 death every 3 minutes, but in January, we have 1 death every 1.3 minutes. So we increase the number of deaths. Next, please. Next. The COVID deaths in the world in October, the last week, so we can see the first one. Mexico is in the fourth place. But when you put into the real numbers, an excess of mortality probably will be in the third or in the second place. Next one. Confirmed cases in Mexico is lower. Why? Because we low testing and high COVID positive according with this graphic. Next one. The real numbers confirmed for the COVID according with the Institute of the Statistics said that the COVID is almost 50% higher than the report of the daily report for the government. Next. So with this situation, COVID is the second cause of death, only behind of the heart disease. Next. 50% of the people die outside of the hospital. They are afraid to go into the hospital because they go to the hospital in case that you die, they don't give you the body because they give you only chance to go into this. This paper is interesting. The BBC wrote one paper for the excess of mortality reported by the government. Finally, next one, the government recognized that they have excess of mortality. We just see in the first line, the number for the government notified is 200,000. But in the real numbers, we have almost 300,000 deaths associated with the COVID. So they start recognized because the pressure for the outside of the country is hard to push them to say that they don't have other numbers because they have. So the government admit finally that we have excess of mortality. Next one, and with this number at that time we have the second country with most deaths ahead to the Brazil. But who are the responsible for this? Two merolicos. They are liars all the time. In the morning, the president, they have the mañaneras in the morning show. They say fake news all the time, and they say that they have other data for the and the other one in the afternoon, the subsecretary of health, they say the same situation at night. So two shows they are shame for Mexico and for the world. So they lie all the time for the people. But in this study, next one, in this study is very interesting. Next, this study was developed by the University of California in San Diego. Was ordered to commission it by the World Health Organization, and they said that almost 190,000 deaths from all causes could be had prevented in Mexico during the pandemic. Next one, if they want management correctly. The main fail for the management of the pandemic was the excessive of concentration in the authority in the president and also for the one executive branch for the health care, for the health secretary. According with the report, the Mexican authorities report excess of mortality more than 300,000. Next one. And you can see in this graphic, in the blue, you can see the mortality according with the government. In the orange, you can see the excess of mortality every week. Next one. But what happens when the politician is wrong? For example, the World Health Organization recommends vaccination for entire health sector first. The president said, it's not appropriate to vaccinate private doctors. So it's ridiculous. Next one. And also the president is not appropriate to vaccinate the doctors in the first line in the private. And why? This is wrong because the pharmacy doctors in Mexico get in the private sector, they get more than 10 million per month consult. So it's ridiculous. Next one. When in October, you see the situation, vaccinated countries, China, 70%, United States, 50%, Germany, 60%, France, 70%, 74%, and blah, blah, blah. And Mexico, they have only 35% vaccinated. So, according with the vaccination in the world, the full vaccinated population is also 36 only. Next one. The population complete vaccinated in Mexico is only 36%. Next one. What is the situation? Why the people die? Because we have comorbidities. The first principal comorbidity that we have in Mexico, this is why increase the mortality, is hypertension, diabetes, and obesity. Next one. In the last week, the Americans registered more than 1.1 million on new cases and 24,000 deaths for COVID. So the situation remains delicate. In one country, it's controlled, but in others, no. This is the fatality. Mexico is one of the first countries that they have the high mortality in the world. Next one. So we need to learn from the history. Let's act smart to keep more people falling into the poverty and help solder the broken pipes in our economy. Let's do it before it's too late. Now it's late to prevent we have 600,000 deaths in the country in the real life. So we need to let's avoid more deaths and we need to offer quality care. The Mexican Academy, we write the paper to send it for the government, and we propose to better training for the medical personnel, nurses, better protection for the personnel and quality equipment, more invest in health, more quality material and equipment, and try to increase this. We are not heroes, we are doctors, and we need the self-respect for the people and for the authorities because they use us when they want to use us. The doctors no are martyrs. The doctors is responsible for the care of the people and the countries. And now in this pandemic, Mexico, the emergency medicine showed that the important situation that they played the role in any system around the world. The emergency medicine showed the big role that we play for the care in any country, in any situation, and any society. Thank you for the invitation, and this is time for invite you to join us in the next World Congress in Mexico is also virtual, 16, 17, 18, and 19 of November. And thank you for inviting me. And Bashar, thank you for the invitation and for all committee to invite me to be here. Thank you, Eric.
Thank you, Carlos. I think we've got time for question.
Yes?
Does anybody have any question? So I have a question for you. You talked all over your presentation about the high rate of infection, mortality, about healthcare, within healthcare professionals in Mexico. And I'm sure this had a huge impact on the capacity of the system to respond. Like, how would you explain this high rate of infection among your healthcare professional? Like, is it protection? Is it...
The situation is that many hospitals that they was reconvected to the COVID hospital. So they are general hospital, and they was reconvected to the COVID hospital. And many of these personnel working in the emergency room, some of them they have risk factor to be there, and they go out to the emergency room, and they contract younger people or younger doctors to be there, and so they don't give material and equipment to protect for the infection, and they don't have correct information about that, and this is why the situation for the doctors, because they don't have the protection, they don't know too much about the disease, they don't know too much about the information to wearing the mask and all this everything. And this is why, and also they was protected sometimes in the hospital, and they don't worry about and they go outside and they take a metro, they take a buses, and they have possibilities to contact with the people with infection, and this is why the number of the doctors was infected.
Thank you. Oh yeah, we have another question. Please give the microphone.
Thank you very much, Dr. Carlos. This is Dr. Behçet. My question is about your deaths. You said about 58% of your deaths have been done out of the hospital. Why? My question is about your deaths. You said, I will repeat it again, about 58% of your deaths, or Mexico deaths, happen out of the hospital. Do you think it happened due to lack of diagnosis, or lack of the treatment, or they afraid to come to hospital, or lack of the staff?
The situation was that I told you the reconversion for the hospital, they don't give treatment for the regular pathology. So the people start with the medias, they start to be afraid that what's going on with this. And the people in Mexico, they don't want to go into the emergency room, because when they go into the emergency room or into the hospital, they don't have contact with the family. So this is cultural things. When you go to the hospital, the family is close to you, next to you in the hospital. So when they go into the hospital, you don't see anymore your family, only by cellular or iPad or whatever, to have contact with them. So if the people died, so they call you and say you, well, your family is dead, so you need to come for the body. And they got into the black package and give you the body, and you don't have contact again with your relative or with your family. In our culture, part of the situation in Mexico is big contact with the dead. So when the people, they don't close the cycle for the dead, they suffer too much the consequence, and they don't give you chance to go into the cemetery, because they don't want to they want to the crematory, but you need to wait 4 or 5 days waiting because the crematory is full. So in our culture, they don't want to be in this situation. This is why they are afraid. And they say, I don't want to be in this situation. I don't go to the hospital. I wait in the last minute to be into the hospital. But they let the disease increase. And when they arrive to the hospital, it's too late. And some people die at home, and also die for the pathology for comorbidities, heart attack, diabetes, ketoacidosis, and other ones, because the hospital was reconverted for the COVID hospital. And the regular pathology, diabetes, hypertension, and all these things, they don't care about that in 1 year. If you have one situation for regular consult, they don't give you situation for accept your patient. So this is why the excess of mortality is not for COVID, it's for the comorbidities plus COVID affected the situation for the healthcare in Mexico.
Thank you. So we are getting close now. I would like to thank the speakers for the lecture, and we hope we'll see you for real, physically, face-to-face, and not with the Zoom. So I hope you enjoy. Thank you for coming, and thank you for being in the room. Thank you. Bye.
Thank you, Carlos.
Thank you.
I can see you. We're waiting for next time. Thank you very much for your support. Thank you.
Okay, thank you. Bye-bye.
Evet, tekrar merhaba. Nasılsınız? Hediyelerimiz var bak. Evet. Baklava yediniz mi? Afiyet olsun. Kim yemedi? Senin suçun. Kim beğendi? Bak sadece bir Zeynep Hoca beğenmiş. Beğendiniz mi? Bir daha getirelim mi? Getirelim. Peki. Evet, değerli arkadaşlar, hepinize tekrar merhaba. Oturumu açıyorum. Bu oturumda gelen arkadaşlar var değil mi? Evet. Bu oturumun yapılmasında destek olan Roche firmasına çok teşekkür ediyoruz. Onlara teşekkür ederek başlıyoruz. Konumuz yeni biyomarkerlardan prokalsitonin acil serviste kullanılması ile ilgili bir sunum olacak. Bu sunumu Atatürk Üniversitesi'nden Acil Tıp Anabilim Dalı'ndan profesör, aynı zamanda ana bilim dalının başkanı Profesör Doktor Zeynep Gökçen Çakır hocamızı hem ATÜDER'in First Lady'si hem başkan yardımcısı, ben de kendisinden çok şey öğrendim. Kendisine çok teşekkür ederek bu sunumu yapmak üzere kürsüye davet ediyorum. Gelmiş zaten.
Behçet Hocama nazik takdimi için çok teşekkür ediyorum. Estağfurullah hocam, ne demek. Birlikte bilgiyi paylaşmaktan keyif aldığımız bilgi dolu arkadaşlarımız hep etrafımızda. Çok teşekkür ediyoruz size de. Zeynep Gökçen Çakır, Behçet Hocam da takdim etti Atatürk Üniversitesi Tıp Fakültesinden, ama beni tanıdınız zaten. Hiç sahnede inmedim geldiğim günden beri. Ben bugün size Roche Diagnostik'in katkılarıyla son zamanda özellikle de COVID-19 pandemisinin patlamasıyla hayatımızda daha belirleyici bir rol alan ve daha çok konuşulan, hatta televizyonlardaki tartışma programlarına kadar inen bir konudan bahsetmek istiyorum. İnen derken burada bir irtifa azalmasından söz etmiyorum. Yani oraları bile kapladığı anlamında söylemek istiyorum. Bu güncel biyomarkerımız prokalsitonin acaba acil servislerde nasıl kullanım alanı buldu? Nasıl kullanılacak? Bugün sizlerle onu konuşacağız. Öncelikle bir biyomarker nedir? Kabaca hepimizin kafasında biyomarkerla ilgili bir tanım var. Normal biyolojik süreçlerin, patolojik süreçlerin, hastalıkların gidişatının veya terapetik bir girişimin sonucunun test edildiği, denendiği, farmakolojik yanıtın bir göstergesi olabilecek ya da hastalığın bir göstergesi olabilecek, objektif olarak test edilebilen, ölçülebilen, değerlendirilebilen herhangi bir protein ya da makromoleküle biyobelirteç diyebiliriz. Dediğim gibi bu herhangi bir protein ya da makromolekül olabilir. Asıl önemlisi burada tanı koydurucu değerinin olması, objektif olarak ölçülebilmesi ve tanı koydurucu ya da bir şeyi ölçümlemede bizim için bir kriter olmasıdır. Biz acilciler olarak çok isteriz böyle çok iyi biyomarkerlar olsun, böyle anında hastalıklara tanı koysun. Çünkü insanların saç telinden ayak parmak ucuna kadar bütün dertlerine bakan insanlarız, bakan doktorlarız burada hepimiz, değil mi? Dolayısıyla da çok isteriz nerede ne var bize söyleyen markerlar, hızlı ve doğru bir şekilde bunları tespit eden markerlar olsun. En çok da bunların hayat tehdit eden kardiyak olaylarda olmasını isteriz. Yine hayat tehdit eden göğüs hastalıkları ile ilgili olayların tanısında, bunların birbirinden ayrılmasında, çünkü biliyorsunuz bir kalbin yarısını bölüşemezler, sağ kalp mi sol kalp mi bir karar veremezler. Keşke ben sağ kalbim diye bağıran bir marker olsa filan diye hep böyle hayal kurarız. Prokalsitonin böyle geniş, aslında biraz sonra tarihçi nasıl bulunduğuna değinirken ne kadar geniş ve farklı alanlarda da aslında bize yol gösterdiğine değineceğim. Böyle bir biyomarker, bizim iyi bir klinik biyomarkerdan beklentimiz kolay ulaşılabilir, ölçülebilir ve sensitifliğinin, spesifikliğinin yüksek olmasıdır diye tekrar ediyorum. Ve prokalsitonin öyküsüne başlıyorum. Bir grup araştırmacı Fransa'da kanser markerları üzerine çalışırken prokalsitonini buldular aslında. Tiroid medüller kanseri üzerine çalışıyorlardı ve onun için mükemmel bir belirteç olan kalsitonin üzerine deneyler yapıyorlardı. Ve bunu yaparken kalsitoninin prekürsörü olan prokalsitonin için monoklonal antikorlar ürettiler. Ve daha sonra da bunun sadece tiroid medüller SEA'da değil, akciğer kanserlerinde de, küçük hücreli özellikle akciğer kanserlerinde de yükselebildiğini gösterdiler. Ve akciğer nöroendokrin hücrelerinden salgılanabiliyor olacağını fikrinden yola çıkarak bunun bir takım şeylerin belirteci olabileceği ile ilgili ilk hipotezleri ortaya atmaya başladılar. İlk tespit ettikleri de aslında bu noktada biraz sekteye uğradı prokastonin ile ilgili gelişmeler. O arada Körfez Savaşı çıktı ve Körfez Savaşı esnasında inhalasyon yanı, savaşların bize öğrettiği çok şey vardır. Acil tıbbın kendisi de aslında İkinci Dünya Savaşı'nın kıyımı üzerinden yükselmiş dinamiklerden bir tanesidir. Bu da prokastonin de böyle bir öyküsü var. Körfez Savaşı'na uzanan bir öyküsü var. Burada Fransızlar çalışmaya devam ediyorlar ve inhalasyon yanığı olsun ya da olmasın yanık hastalarında, kanser hastalarında görülenden çok daha yüksek bir prokastonin düzeyi olduğunu görüyorlar. Ve ağır sepsis ya da septik şok, kardiyojenik şok ile ilişkilerini yavaş yavaş oturtmaya, kurmaya başlıyorlar. Gönüllü denekler üzerinde endotoksin enjeksiyonu yapıyorlar. 1994 yılına dayanıyor bu çalışma. Ve prokastonin düzeylerinin arttığını gözlemliyorlar. Biyolojik bir belirteç olabileceğini o zamandan öngörüp bir süreci tetiklemiş oluyorlar. Geldiğimiz noktada bugün prokastonin 114 amino asitten oluşan bir polipeptittir. Başta saydığımız mükemmel biyobelirteç kriterlerine uyup uymadığını isterseniz sunumumun sonrasında, devamından sonra birlikte yine karar verelim. Sistemik enfeksiyonlarda kalsitonin genleri parenkim hücrelerinde aynı anda ekspresi olur ve esas itibariyle tüm vücut bir endokrin organa dönüşür. Ve bu da prokalsitonin üretimini sinerjik olarak uyaran bir medyatör yanıtı oluşturur. Ayrıca gastrointestinal perfüzyon bozukluğu sonucu olarak bağırsak duvarı boyunca tetiklenen bakteriyel translokasyon ve hem septik hem kardiyojenik şok durumunda da prokalsitoninin neden artmış olabileceğini açıklayan bir takım kaskatların tetiklendiğini bilimsel olarak gösterdiler araştırmacılar. Ve bunun bir hormonkin medyatör olarak tanımladılar. Bu gelişmeleri bir hormonkin medyatör olarak prokalsitonin üzerinden tanımladılar. Hem inflamatuar sürecin hem de tiroidden salgılanan prokalsitoninin dolaşıma salınmasını görüyorsunuz. Evet, bugün geldiğimiz noktada akut enflamasyonda ve eksojen enfeksiyonlarda invaze olan mikroorganizmalarla savaşta metabolizma ve vasküler tonus adaptasyonu için prokalsitonine ihtiyaç duyulduğu, bunun bir immün reaktif kalsitonin olarak tanımlanacak kadar immün olaylarla alakalı olduğu gösterilmiştir. Prokalsitoninin bir diğer adı immün reaktif kalsitonindir. Pankreatit ve septik şokta olan kritik hastalarda, yanıklarda, akciğer zedelenmelerinde hani inhalasyon yanığı olsun olmasın dedik çıkış noktalarını söylerken Fransız bilim adamlarının. Çocuklarda menenjitte, yeni doğan enfeksiyonlarında, erişkin yoğun bakım ünitelerinde buralarda sepsis takip edilirken özellikle de hem diagnostik hem de prognostik değerinin olduğu yavaş yavaş gösterilmeye ve oturmaya başladı. İşte uzun bir liste halinde bazı kullanım alanlarını görüyorsunuz. Bunların içerisinde koa, konjestif kalp yetmezliği gibi hastalıklar da var. Biz her ne kadar bugün ağırlıklı olarak bir enfeksiyon durumunun gösterilmesi ve antibiyotik tedavisini nasıl etkilediği üzerinde duracaksak da böyle uzun bir listenin belirteci olabilecek kadar geniş kullanım alanına sahip bir belirteç diyebiliriz. Enfeksiyonla ilgisine gelince nasıl salgılandığını enfeksiyonda söyledik. Enfeksiyonun 6 ve 12. saatleri içerisinde seri bir yükselme gösterir ve enfeksiyon kontrol altına alındığında prokalsitonin her gün yarısına iner. Bir önceki dozun yarısına iner. Ben bunu biraz bu gebelik hormonlarının yükselişine benzetiyorum. Böyle bir logaritmik yükselişi vardır. Ve riskli hastalarda elimizdeki mevcut delillere ek prognostik bize faydalar sunar. Bir hasta antibiyotik tedavisi altında olmasına rağmen prokalsitoninde bir artış varsa bu muhtemel bir ölümün erken bir belirteci olabilir diye aklımızda bulunmalı. Evet, enteresan bir bulgu Nakamura, bir Japon bilim adamının çalışmasıyla ortaya çıktı 2013'te. Akut bakteriyel enfeksiyonlar ve sepsiste en yüksek değerlerdedir prokastonin. Evet, ama otoimmün aracılı enflamasyonda veya lokalize enfeksiyonlarda, mesela apse gibi, ampiyem gibi yükselmemektedir. Kıymetli bir oranda, yol gösterici bir oranda yükselmemektedir. Çinli bilim adamları bu sefer de yine 2013 yılında sadece bakteriyel enfeksiyonlarda değil, fungal enfeksiyonlarda da değerli olabileceğine vurgu yapmışlardır. Yine bir çalışma C-reaktif proteinle, SRP ile kıyaslıyor enflamasyon durumunda. Biliyorsunuz bu C-reaktif proteinin hastaları var. Yani C-reaktif protein olmadan hasta değerlendiremem diyen hekim arkadaşlarımız var. O kadar seviyorlar. Siz düşünün ki C-reaktif proteinle kıyaslanmış ve geniş bir meta analiz sonucunda C-reaktif proteinden daha neredeyse yüksek bir tanı koydurucu değeri olduğu tespit edilmiş. Evet, enfeksiyöz veya non-enfeksiyöz nedenlerle yükselebiliyor. Çünkü gördük az evvel nerelerde işimize yaradığını. Nöroendokrin tümörler bunların başında geliyor. Non-enfeksiyöz bazı sistemik enflamasyonlarda, bakın lokal enflamasyonlarda yükselmediğine vurgu yaptık ama sistemik enfeksiyonlarda enflamasyonlarda, non-enfeksiyöz enflamasyonlarda yükselebiliyor. Ama asıl ağır enfeksiyon ve sepsis durumlarında neredeyse tanı koydurucu, neredeyse demeyelim, tanı koydurucu ve prognoz takibi için önemli bir yeri var. Non-enfeksiyöz pozitiflikleri, bu acaba yalancı pozitiflik diyebilir miyiz? Eğer enfeksiyöz bir nedeni araştırıyorsak, bakmak istediğimiz şey buysa, evet bu bir yalancı pozitiflik ama aslında bu prokalsitoninin hassas bir enflamasyon ve akut faz reaktanı olduğunun göstergesidir diyelim. Peki tek PCT ölçümü, prokalsitonin ölçümü mü yapalım yoksa seri ölçümler mi yapalım? İlk 3-4 saat için yükselmeye başlıyor ama kan düzeyi 12-24 saat içerisinde pik yapıyor ve dolayısıyla da hasta takibi sırasında henüz böyle troponin gibi filan tanımlanmış, şu aralıklarla ölçülmelidir diye bir şey ortaya konmadıysa da hasta takibi sırasında belirli aralıklarla ölçülmesinde fayda var. Peki kılavuzlar ne diyor prokalsitonin konusunda? Sepsis tanısı için sensitivitesi ve spesifitesi %70'ler civarında. Biri %77, biri %79. Ama alt solunum yolu enfeksiyonları için sensitivitesi %94.1, spesifitesi %88.4, yani çok daha yüksek. Neden alt solunum yollarında bu kadar yüksek olması bizim için önemli? Çünkü COVID ile hayatımıza giren pnömoni bunu bizim için böyle prokalsitonini altın değerinde bir şey haline getirme üzere, o yüzden. Evet, negatif prediktif değeri de %89'a 94 aralığındadır. Hem sepsis hem alt solunum yolu enfeksiyonlarında. 2016 kılavuzunda enfeksiyon hastalıkları, Amerikan Enfeksiyon Hastalıkları Birliği'nin 2016 kılavuzunda hem hastane kaynaklı hem de ventilatör kaynaklı pnömoninin yönetiminde antibiyotik tedavisinin başlanmasına karar aşamasında başlanması durumunda ve karar aşamasında buna karar vermede prokalsitonin kullanımını önermiyor hiçbir şekilde. Ve bu öneri düzeyi de oldukça yüksek. Güçlü bir öneri ve orta düzeyde kanıt düzeyine sahip. Önermiyoruz diyorlar. Hem ventilatöre bağlı hastalarda hem de ventilatöre bağlı olmayan hastalarda. Avrupa Kardiyoloji Birliği ise kalp yetmezliği kılavuzlarında akut kalp yetmezlikli hastalarda prokalsitonin seviyelerinin belirlenmesinin pnömoni ayrıcı tanısının tespit edilmesi ve antibiyotik tedavi kararlarına rehberlik etmesi için önermektedir. Bu da yine kanıt değeri yüksek bir öneridir. Koa alevlenmesiyle başvuran hastalarda antibiyoterapi verilip verilmemesi kararında prokalsitoninin rolüne kesin karar verilememiştir. Henüz koahla ilgili kılavuzlarda bunda belirleyici bir cümle kurulmamıştır. Çok sayıda randomize kontrollü çalışma yan etki sıklığında herhangi bir artış olmadan daha az antibiyotik reçete edilmesini ve daha kısa antibiyotik kullanım sürelerini, ki bunlar bizim için çok değerli, bu iyi sonuçlara yol açabileceğine vurgu yapmıştır. Randomize kontrollü klinik çalışmalarda elimizdeki değerli kanıt düzeyleridir aslında. Henüz kılavuzlarla da yer almamakla birlikte. Evet, doğru tanılara katkıda bulunmanın yanı sıra prokalsitonin için mikrobiyal invazyonun şiddetini, yayılımını bunlarla koreli olarak gösterdiğine dair de elimizde kanıtlar var. Ve yüksek prokalsitonin seviyeleri daha kötü prognoz ile ilişkili olduğunun da altı çizilmiş durumda. Mesela prokalsitonin düzeyi 0,25 nanogram mililitrenin altında olan alt solunum yolu enfeksiyonu olan hastalarda antibiyoterapinin artık kesilebileceğini söyleriz. Ama sepsis hastaları için bu değeri 0,50 nanogram mililitrenin altı olarak kabul ederiz. Bu da 2011 yılında yapılmış kıymetli bir çalışmanın sonucu olarak yer aldı. PAS çalışması bir grup çalışması prokalsitoninle ilgili. Prokalsitonin değerlerindeki değişmeleri gözeterek antibiyotik ekleme, biz buna escalate diyoruz veya antibiyotiği çıkarma, descalate yönünde kararların alınabileceğine vurgu yapan bir çalışmadır. Akılcı antibiyotik kullanımı, antibiyotiklerin toplum halk sağlığını kötü etkileyici antibiyotik kullanımının, kötü antibiyotik kullanımının halk sağlığını derinden kötü etkilediğini biliyoruz. Bunların önüne geçmesi açısından. Ama sepsis yalnızca tam tanımlanmamış heterojen bir klinik sendrom. Yani farklı nedenlere bağlı olabilir, tanısını koymak çok zor olabilir. Biliyorsunuz sepsisi tanıyabilmek için, klinik olarak sepsistir diyebilmek için bir sürü farklı algoritmalar geliştiriyoruz. Dolayısıyla buradaki bir tanı kriteri bizim için değerli olacaktır. Gördüğünüz gibi böyle bir gözlemsel ve müdahale içeren çalışmalar, yani kontrollü randomize çalışmalarla gözlemsel çalışmaların kıyaslandığı bir metaanaliz var ve mevcut kanıtlar gözlemsel ve randomize kontrollü çalışmalar incelenerek derleniyor ve prokalsitonin kullanımının yararlarıyla zararlarını detaylı olarak incelemiş oluyor. Burada görmüş olduğunuz soru işaretleri yeteri kadar aydınlatılmamış durumları. Çift pozitiflikler iyi çalıştığı, prokalsitoninle ilgili göstergelerin iyi çalıştığı yerleri gösteriyor. 3 pozitiflikte daha ciddi çalıştığı yerleri gösteriyor diye özetleyebiliriz bu çalışmayı. Evet, bu çalışmada da yine artık COVID'e de değinmeden, birkaç slaytta da COVID'den bahsetmeden prokalsitonin sunumunu sonuçlandıramayız diye düşünüyorum. Bu kadar alt solunum yolu enfeksiyonları için belirleyiciyken. Tabii ki 2019 yılında tanıştığımız COVID'in 2020 yılında menşeini aldığı, çıktığı topraklarda Çin'de yapılmış bir çalışması prokalsitonin değerinin yoğun bakım alınan hastalarda anlamlı derecede yüksek olduğunu buldu. Ve bu da COVID-19 olduğu onaylanan hastalarda yapılan 4 çalışmadan derlenen bir meta-analiz. Bu meta-analizin sonuçları ve COVID-19 şiddetinin artması riskiyle ilişkilendirildi. Bu meta-analizin sonuçları prokalsitonin yüksekliğinin COVID-19 şiddetinin artmasıyla bağlantılı olduğunu gösterdi. Ve bakteriyel bir koenfeksiyona da işaret edebileceğine vurgu yaptı. Evet, sonuç olarak biz istiyoruz ki, gönül istiyor ki işte acil yoğunluğu içinde konuşmamın en başında da söylediğim gibi çok fazla bizi yormayacak, böyle çok fazla bizi klinik değerlendirmeler içerisinde tekrar muayene edeyim, tekrar anemnez alayım, hangi görüntülemeyi istediğim şeyine sokmayacak, böyle tıkır tıkır biyobelirteçler olsun ama henüz hiçbir biyobelirteç bu özelliğe sahip değil. Ama buraya kadar anlattıklarımdan herhalde prokalsitoninin burada önemli bir yer alabilecek bir biyobelirteç olarak kendini göstermeye başladığına vurgu yapmıştır diye düşünüyorum. Ve acil servislerde, ilk basamak sağlık hizmetlerinde, yoğun bakım ünitelerinde hekim kararlarını yönlendirmede etkin olarak kullanılabileceğine vurgu yapmak istiyorum tekrar. Çok teşekkür ediyorum ben sabrınız, dikkatiniz burada olduğunuz için.
Çok teşekkür ediyorum Zeynep Hocam. Hem erken dönemde bitirdiniz hem de güzel bir şekilde özetlediniz. Ben de bir cümleyle özetlemiş olayım. Bu yeni biyobelirteçlerden olan prokalsitonin acil servislerde bir hastalığın enflamasyonu ve enfeksiyonun birisi ciddiyetini anlamakta, ikincisi prognozunu anlatmakta, üçüncüsü de verdiğimiz tedaviye olan yanıtını anlamak açısından kullanabiliriz. öneriliyor. Biz de hem kullanıyoruz hem de öneriyoruz. Bu 3 nedenden dolayı bu biyo belirticin acil servislerde kullanılmasını tavsiye ediyoruz. Böyle faydaları var. Çok teşekkür ediyorum. Ben soru veya katkı varsa ışıkları açabilir misiniz?
Sayın Hocam öncelikle çok teşekkürler. Doktor Ahmet İstanbul Kanuni'nden. Benim ufak bir katkım, nacizane haddim olmadan ufak bir sorum olacak. Özellikle maniteli hastalarda acil servise çok sık başvurular oluyor. Genel durum bozukluğu, oral almazlığı gibi. Bu hastalarda biz enfeksiyöz mu, metabolik bir hadise mi ayırmada, zaten CRP yüksekliği varken hani bir sebebi ayırmada prokalsiyon elimizde gerçekten çok güçlü bir belirteç olarak duruyor. Hani, özellikle maniteli hastalarda çok daha sık kullandığımız, daha doğru yönlendirilmiş belirteç. İkinci olarak da romatoid artrit gibi romatizmal hastalıklarda inflamasyon baskılayıcı tocilizumab veyahut da diğer monoklonal ajanlardan sonra baskılanan CRP düzeyleri bir enfeksiyöz süreci bize düşünülmezken bu hastalarda yine prokalsisyonu etkilemediği için bizi yine enfeksiyöz süreçleri, septik süreçlere daha yönlendiriyor.
Daha iyi takip edebiliyoruz, evet.
Bu katkım sormak istediğim soru ise şu hocam. Prokalsiyon düzeyi sizin de belirttiğiniz üzere bizde sepsisin ciddiyetini de belirtiyor. Yani enfeksiyöz sürecinin ciddiyetini de belirtiyor. Klinik olarak, klinik tecrübenizde sizin bir cut-off değeriniz var mıdır? Prokalsiyon düzeyi 2 iken ben seftriaksiyon başlayayım misal veyahut 15, 18 meropeneme geçeyim gibi bir cut-off değeriniz var mıdır sizin bu durumda kullandığınız?
Ben bu sorun için bu yoğun bakımda bunu yoğun olarak kullanan ve çok geniş bir hasta popülasyonunda denemiş olan Başar Hocam'dan fikir almak istiyorum. Hocam böyle bir cut-off değeri sizde oluştu mu? Biz henüz o kadar çok, hele de COVID-19 döneminde o kadar çok sepsis hastasında henüz denemedik. Bununla ilgili bir şey oluşacak kadar kafamızda. Ama Başar Hocam'ın bu konuda çok ciddi bir deneyimi olduğunu hepimiz biliyoruz.
Çok teşekkürler. Şimdi tabii biz özellikle bu prokalsitonini sanıyorum 7-8 yıldan beri aslında kullandığımız ve hasta yönetiminde, takibinde kullandığımız parametreyken özellikle son 2-3 yılda daha çok hani yaygın kullanıma geçti. Yani biz daha 7-8 yıl öncesinden aslında prokalsitonin ile takip edelim hastaları diyorduk. Ama o zaman birçok branş hatta enfeksiyon hastalıkları yanaşmıyordu. Ama süreç içinde prokalsitonun ne kadar önemli olduğunu özellikle COVID salgınlarında antibiyotik başlayacak mıyız, başlamayacak mıyız? Ona prokalsitonle karar verdik. Şimdi bu prokalsitonun 2 ile 5 arasındaki değerlerini tabii şeylere göre değişmekle birlikte eğer ek patolojiler yoksa bakteriyel enfeksiyon değine kullanabiliriz ama bunun prognostik değerini komple birlikte hasta kliniği, CRP, albumin ve enfeksiyon
Akut faz
reaktanlarıyla birlikte hep aşıdan akut faz reaktanlarıyla birlikte değerlendirmek mantıklı. Şöyle bir şey yok yalnız Ahmet, o konu yok. Yani bu prokalsisyonu çok yüksek, o halde hasta çok ağır. Öyle bir şey yok. Bir bakıyorsun hastanın prokalsiyon değeri çok fazla ama daha düşük olan kişi daha ağır olabiliyor. Demek ki vücudun cevabını tek bir şeyle algılayamıyoruz. Oradan çıkıyor bu sonuç. Nitekim BNP'de de böyle bir şey yaşamıştık. BNP'de de mesela vücudun yanıtını değerlendirirken mesela BNP ne kadar yüksekse o kadar tablo korelasyon gösteriyor. Öyle yok. Öyle bir şey değil. Dolayısıyla yani burada yine hep size söylediğim tabii derslerden 2 kere 2 4 olmadığı için insan vücudu aynı rakam cevabını vermez. Rakam o yüzden ne oluşturuyoruz? Cut-off değeri oluşturuyoruz. Yani bizim için 2-5'in aralığının üzerinde olan yoğun bakım grubu hastalarda bunun artık daha ciddi bir enfeksiyon olduğunu kabul ediyoruz. Ama yükseldikçe de prognostik değerinin de buna göre değiştiğini kabul edebiliriz. Korelasyon olmadığını tekrarlayayım. Yani ne kadar yüksekse o kadar kötü. Öyle değil. Sadece cut-off'umuz var.
Çok teşekkür ederim Başar Hocam değerli katkılarınızdan dolayı. Başka katkı soru var mı sınıftan? Bugün bu saate kadar bizleri böyle dinlediğiniz için ben de içimden gelerek size bir hediye sunmak istiyorum. Ama soru soracağım. Bugün acil tıp uzmanlığına 16 Ekim biliyorsunuz. Bugün itibariyle yani bugün asistan olan var mı 16 Ekim'de? Acil tıp için asistanlığa başlayan var mı?
Tarih olarak
Uzman olan var mı?
16 Ekim mi?
Peki bugün doğan var mı? Doğum günü bugün olan var mı? Evlilik kimdir? Bir ayağa kalkabilir misiniz rica ederim? Mikrofon
Hocam
verebilir misiniz?
evlilik yıl dönümünü
Mikrofon.
bilen bir erkeğe rastladık. Bence hemen ödül verelim. Daha fazla bir şey sormaya gerek yok.
Hocam yani bayanlar da olsaydı. Bakalım belki bir şey isteyeceğim hocam. Kendinizi tanıtır mısınız?
Doktor İbrahim Aydın, Kartal Lütfi Kırdar Şehir Hastanesi Acil Tıp Kliniğinde asistanım.
Evet, bugün evlendiniz.
Maşallah.
Evlilik
Evet.
cüzdanınız var mı yanınızda?
Yanımda yok hocam.
Yok.
7 sene oldu ama.
Ama
net
bize
bir şekilde.
ibraz edeceksiniz değil mi?
Tabii ki hocam.
Daha evlisiniz yani ayrılmadınız.
Çok şükür.
İnşallah. Uzun evlilikler diliyorum inşallah
Amin.
ömrü sonuna kadar. Ben de burada başkanımız burada, başkan yardımcımız da burada. Onlara sığınarak şunu demek istiyorum. İbrahim hocam, ATÜDER'in 2022 yılında yurt dışında yapacağı ilk aktiviteyi sizi sponsor olarak götürecektir.
Çok teşekkür ederim hocam. Çok sağ olun.
Evet. Hayırlı olsun. Bize ulaşabilirsiniz. Değil
Çok
mi
güzel
Zeynep
bir
hocam?
ödül ve dediğim gibi İbrahim bu ödülü fazlasıyla hak ediyor.
Çok sağ olun hocam.
Evlilik
Başar
yıl
hocam.
dönümünü hatırlayan bir erkek olarak.
Evet, Başar hocam da okey diyor. Bir tane de çekeyim. Yok. Evet. Yoruldunuz biliyorum. Şimdi
Sayın Başkanım ben sahneden ineyim mi?
yok sahne sizi seviyor, siz de sahneye yakışıyorsunuz hocam.
Teşekkür ediyorum.
Evet, ben tabii ki hocam lütfen. Değerli arkadaşlar, Zeynep hocama çok teşekkür ediyoruz. Bu sunumu yapan Zeynep hocama çok teşekkür ediyoruz. Bu oturumun yapılmasında katkı sunan Roche firmasına kendilerine teşekkür ediyoruz. Buradalar mı bilmiyorum. Burada olsalardı onlara da bir hediye verdirecektik ama burada mısınız? Bir ayağa kalkabilir misiniz? Tamam. Çok güzel. Evet. Bak ben şimdi hediyeden bahsedeceğim de korktular yani. Yok bir şey yok. Siz de bizleri dinlediğiniz için size de çok teşekkür ediyoruz. Hediyenizi başka bir zamana çekeceğiz. Oturumu kapatıyoruz. Çok teşekkür ederim.
Teşekkür ederiz.
To improve recognition of early sepsis at the ED and develop novel therapy for patients with sepsis. In this presentation, I will share you some results of preclinical research. Still closer? Yeah, okay, thanks. So I will share you results from our preclinical research. It's very fundamental, so in contrast to some of the other talks we saw, in which we identified the molecular mechanisms that we think that lead to organ failure in sepsis. So why sepsis? Well, sepsis is a very common disease. The Global Burden of Disease study estimated that it's the most common cause of death worldwide. And annually, around 50 million people per year are affected by sepsis. And these estimates are from 2017, meaning that it's even before the COVID-19 pandemic. So numbers are even higher. Approximately 1 in 4 to 1 in 5 cases is fatal, which means that every 4 seconds someone dies of sepsis somewhere in the world. 2% of all hospital admissions are because of sepsis. So it's something that we see very commonly, and is unfortunately all around the world still has a high mortality rate. However, the exact mechanisms that lead to organ failure remain not precisely known, although we do appreciate that sepsis is caused by an infection, which might be a bacteria, a virus, or another pathogen. We do not understand why some people develop organ failure and other people do not. So that's the main question. And here in this talk, I will focus on the role of the mitochondrion. So our cellular powerhouses responsible for maintaining cellular homeostasis by producing our energy in the form of ATP. And at the same moment, these mitochondria always produce a bit of some small amount of free radicals that are toxic to the cells. The reason that I'm interested in mitochondria and sepsis is based on this paper and also other papers demonstrating that there is an association between biomarkers for mitochondrial failure and outcome in sepsis. And in this study, they measured the mitochondrial membrane potential in platelets in patients admitted to the ICU because of sepsis. And as you can see, upon admission in patients with sepsis, both survivors and non-survivors, the mitochondrial membrane potential was lower as compared to patients without sepsis, the control. And in patients who survived sepsis, during follow-up, the mitochondrial membrane potential was restored. Well, similar data is available from muscle biopsies from patients with sepsis at the ICU, demonstrating that there is an association between mitochondrial failure and outcome in sepsis. If you look into preclinical studies in mice, we found this data published in 2015 by another group, not me. They demonstrated that if you induce sepsis in mice and you investigate mitochondrial damage by looking at the mitochondrial DNA in muscles, that there was persisting mitochondrial DNA damage in sepsis. And you can see it here in the graph. And what they did is they performed this gel electrophoresis. They amplified part of the mitochondrial DNA. Under normal circumstances, it should give one band, as you can see in the control groups. But in the septic mice, you see this smear, which means that the mitochondrial DNA is damaged, it's fragmented. And we were wondering whether this also occurs in humans or whether this is something specific to animals. So what we did is that we took renal biopsies from patients with sepsis. And because it's ethically unacceptable to do it at the ED, we had to use biopsies from patients who died of sepsis. And we took these biopsies within 30 minutes post-mortem. And as control tissue, we had a piece of healthy tissue that was removed during a nephrectomy from patients with a renal cell carcinoma. If you look at these biopsies, you can see that there are increased signs of oxidation of mitochondrial DNA. And the oxidation is shown in panel D, where you can see the brown staining, and this brown is oxidized DNA. You can see the same if you look in panel M, the 8-oxo-G, which is also oxidation of DNA. And this oxidation is the first step, damage due to free radicals that could lead to damage to the DNA. So it might be that free radicals derived from mitochondrial failure lead to oxidation of DNA. In the same biopsies, we also investigated DNA damage. And if you look at the right-hand corner, you can see that in the control we have nice bands, but these upper bands disappear in patients with sepsis, which is a clear sign of mitochondrial DNA damage. We investigated several markers associated with mitochondrial DNA repair, mitochondrial repair, that are termed together the mitochondrial quality control. And we found that these were actually reduced in expression. So even though patients with sepsis have increased signs of mitochondrial DNA damage in the kidney, there's no or even downregulation of repair programs in the kidney. And ultimately, we demonstrated that that it leads to a reduced mitochondrial mass that we measured using the mitochondrial DNA copy number in the kidney. So the next question was, now that we know that on the one hand, sepsis is associated with increased biomarkers for mitochondrial dysfunction is associated with poor survival, and we have direct evidence for mitochondrial damage in the kidney. What causes this mitochondrial dysfunction? So we moved to preclinical models, and here we used endothelial cells. Endothelial cells derived from human umbilical cords, so it's a human cell model. What we did is that we used LPS to stimulate the cells and to mimic sepsis. And the first question was, does it lead to mitochondrial dysfunction? And if so, does it depend on uptake of this endotoxin? And as you can see in the fluorescent images, you see that the green, the LPS, is taken up in the cells, and it's co-localized with TOM20, which are mitochondria. So it seems that this LPS is taken up and transported to mitochondria. If we block endocytosis using dinosaur or SSO, which is a fatty acid transporter, the lower two rows, there you see a reduced uptake of LPS. In the right-hand corner, you can see the mitochondrial membrane potential that decreases as soon as we give the cells LPS, and LPS is in the red bar, the blue bars are control, and you see a massive rise in reactive oxygen species as soon as you stimulate cells with LPS. Both of these effects could be prevented if we blocked endocytosis by dinosaur. The next question was, are mitochondria relevant for the induction of cellular stress? So what we did is that we depleted endothelial cells from mitochondria. So we had endothelial cells without mitochondria, and we gave them endotoxin again. And here you can see the mitochondrial membrane potential, JC1. It remained stable. It was unaffected by LPS in these cells. But also we did not see a rise in reactive oxygen species. So it seems that indeed mitochondria are relevant for the induction of stress. And if you look at endothelial leakage, which is shown by albumin leakage over an endothelial barrier, you can see that if you give LPS to the cells, that it leaks over the endothelial cell barrier. But if you have endothelial cells without mitochondria, then these endothelial cells are resistant against injury induced by LPS because there's no albumin leakage over this endothelial cell barrier. So then we dive further into this matter. For those who might not use their biochemical knowledge on a daily basis, I've shown here the electron transport chain in the mitochondria. And what we did here is that we identified the position, the place in the electron transport chain where LPS leads to damage. And you can see that using the substrates for complex 1, 2, and 3, we have a reduced oxygen consumption that's shown in the graph. But if we bypass cytochrome C, complex 3 and cytochrome C, then we don't see any effects of LPS, meaning that the injury induced by LPS is around complex 3 or cytochrome C. It's between complex 2 and complex 4. And that's what you can see in the graphs here. Using isolated cytochrome C, we demonstrated that LPS actually binds cytochrome C, and we also demonstrated that LPS oxidizes cytochrome C after this direct binding. And now we come to the next question, which is this relevant and does it lead to mitochondrial dysfunction and can we prevent it? So we demonstrated that LPS is taken up in cells. It's transported towards mitochondria. Within mitochondria, it oxidizes cytochrome C. So the next question is, can we prevent it? Which means, can we reduce cytochrome C and thereby prevent the injury induced by LPS? Hydrogen sulfide, well known for its toxicity if you are exposed to it in increased levels. We also produce it endogenously in our body in very low levels. And hydrogen sulfide is a very important molecule in our body. It has anti-inflammatory properties, antioxidant properties, and in very low levels you also use it to produce ATP. So it's an alternative electron donor in contrast to, for example, glutamate and malate that are derived from glucose. That donates our electrons in the electron transport chain and ultimately stimulates ATP production. For this experiment, it's relevant that hydrogen sulfide is also a reductor of cytochrome C. And in the line graph on the right upper hand corner, you can see that if we incubate cytochrome C with LPS, you see this peak arising, which means that there is oxidation of cytochrome C. And if we give hydrogen sulfide using the GYY compound, we can prevent oxidation of cytochrome C. Okay, so this is very molecular. What does it mean for a whole organism and might it mean for humans? If we induce sepsis in mice, we can also see in the kidney that there's localization of LPS in the kidney that you can see here in the microscopy images. In the kidney it co-localizes with mitochondria, so also in the mouse after induction of sepsis by ligating and puncturing the cecum, you have translocation of LPS from the gut into the kidney and uptake in mitochondria. Of course, this leads to an increased level of IL-6, a reduction in membrane potential as measured by JC1, and an increase in urea indicative of acute kidney injury. If you pre-treat these animals with hydrogen sulfide donor GYY, you can see that there was no increases in IL-6. It maintained mitochondrial membrane potential, and it also prevented acute kidney injury. So, if we then conclude and we go from mechanisms that induce organ failure to potential strategies to improve outcome, I demonstrated that of course, it's important to improve early recognition, as all kinds of pathogens could lead to organ failure in an infection and thereby induce sepsis. It's important to, of course, rationally use antibiotics and thereby prevent resistance. What it demonstrated here is one of the key mechanisms that lead to organ failure in sepsis, namely that endocytosis of bacterial endotoxins, as we demonstrated in mice, to occur and in cells, leads to mitochondrial dysfunction. So these endotoxins are taken up by the cells, are translocated to mitochondria, and there directly interact with cytochrome C. I demonstrated that hydrogen sulfide, but also other antioxidants, can prevent oxidation of cytochrome C, and thereby also prevent mitochondrial damage and organ failure in sepsis. And ultimately, oxidation of mitochondrial DNA damage that leads to damage, also damage to the mitochondrial DNA, might be an explanation for the poor long-term outcome of patients who had sepsis. And with that, I would like to end. I would like to thank you for your attention and welcome to answer any questions.
Thank you, Dr. Bauma. Is there any questions for Dr. Bauma? I want to talk a little, if you allow me. Thank you for your nice presentation, and we all know that COVID-19 sepsis is also related by mitochondrial destruction, and it seems that mitochondrial destruction is related by organ dysfunction in COVID-19 also, and you better know than me, I think. So this area is will be a hot topic in next days, I think. Thank you, Doctor.
Yeah, thank you.
Now, for the second lecture, Dr. Umut Ocak from Bursa, Turkey.
Dear Chair and dear colleagues, I'm Dr. Umut Ocak from Bursa Yüksek İhtisas Training and Research Hospital. Good evening to all. At first, I would like to thank EPAD and the president of EPAD, Professor Dr. Bashar Jander, for having me here. You know, all the emergency physicians know stroke very well. So today we're going to go over acute ischemic stroke as quickly as possible. And there's nothing to declare. And the presentation content is as shown. And stroke has been defined as an episode of neurological dysfunction caused by focal, cerebral, spinal, or retinal infarction or hemorrhage lasting more than 24 hours or for any duration with evidence of focal infarction or hemorrhage associated with the symptoms. And stroke is a life-threatening disorder and remains a major cause of long-term disability and mortality despite recent advances in both the diagnosis and management strategies. Provision of appropriate care to the patients suffering acute ischemic stroke requires a multidisciplinary approach given the well-established relation of timely and accurate management on post-stroke outcomes. The etiology of ischemic stroke is due to either a thrombotic or embolic event that causes a decrease in blood flow to the brain. In a thrombotic event, the blood flow to the brain is obstructed within the blood vessel due to dysfunction within the vessel itself, usually secondary to atherosclerotic disease, arterial dissection, fibromuscular dysplasia, or inflammatory condition. In an embolic event, debris from elsewhere in the body blocks blood flow through the affected vessel. The etiology of stroke affects both prognosis and outcomes. Stroke is the second leading cause of death and disability worldwide beyond ischemic heart disease. And unfortunately, stroke is responsible for 10% of all deaths worldwide. And age, sex, geography, ethnicity, and socioeconomic status have considerable influence on stroke incidence and prevalence. And patients typically present with sudden onset of a focal neurologic deficit, and the most common findings of physical examination are unilateral weakness and speech disturbance. Patients with suspected acute stroke should have a rapid initial evaluation for airway, breathing, and circulation. A neurological examination should be conducted to determine focal neurological deficits and assess stroke severity. A standardized stroke scale should be used, such as the National Institutes of Health Stroke Scale, and assessment in the acute phase should include heart rate and rhythm, blood pressure, temperature, oxygen saturation, hydration status, and presence of seizure activity. Acute blood work should be conducted as part of the initial evaluation. And the National Institute of Health Stroke Scale is most commonly used to measure the severity of the stroke and has 11 categories and a score that ranges from 0 to 42. This evaluation yields a NIHSS score ranging between 0 means no obvious deficit and 42 means tetraplegia and deep coma, which determines stroke severity as mild stroke when the score is below 8. A moderate stroke when the score is from 9 to 15, and severe stroke when the score is greater than 16. The stroke scale should be performed in the order listed, and each score is based on the patient's action on the exam, and it is not prediction of what the patient can do. And with the use of NIHSS, level of consciousness, language, extraocular movements, and etc. are evaluated within minutes. And differentials include complicated migraines, drug toxicity, and hypoglycemia, hyperglycemia, seizure, syncope, and etc. So, what should emergency physician do during the management phase, acute management phase of stroke? First, we should identify signs and symptoms of possible acute ischemic stroke and we should activate emergency response if needed. So critical emergency medicine assessments and actions are: first, 1, support ABC, 2, perform pre-hospital stroke assessment, 3, establish time of symptom onset, 4, triage to stroke center, 5, alert hospital, 6, check glucose if possible. And immediate general assessment and stabilizations are 1, assess ABCs again and vital signs also, and provide oxygen if hypoxemia, if the patient is hypoxemic, and obtain IV access and perform laboratory assessments, and check glucose rate if indicated, and perform neurological screening assessment, and activate stroke team and order emergency CT scan or MRI of brain, and obtain 12-lead EKG. An immediate neurological assessment by stroke team or designing a first review patient history, establish time of symptom onset or last known normal, and 3, perform neurologic examination NIH stroke score. In patients who probably have acute ischemic stroke, imaging is a crucial part of both the diagnosis and management, and CT has excellent sensitivity to recent hemorrhage and is generally adequate as initial imaging, whereas its sensitivity to recent ischemia is poor, and particularly if the ischemia is small and restricted to the posterior fossa. And all patients with suspected acute stroke should undergo brain imaging with non-contrast CT or MR. And all patients with suspected acute ischemic stroke who arrive within 4.5 hours and are potentially eligible for intravenous thrombolysis should undergo immediate brain imaging with CT without delay to determine eligibility for thrombolysis. And all patients with suspected acute ischemic stroke who arrive within 6 hours and are potentially eligible for endovascular thrombectomy should undergo immediate brain imaging with CT and CTA without delay. Resultantly, all patients with suspected acute ischemic stroke should receive a CAT scan in order to exclude intracranial hemorrhage. So given the benefit of intravenous alteplase as time-dependent, patients are recommended to undergo a CT within 20 minutes upon arrival in order to determine potential indications for IV thrombolysis. Of note, although signs of early ischemic changes, such as hypoattenuation of damaged brain parenchyma, insular ribbon sign, hyperdense MCA sign are well accepted. Early ischemic changes on CT can be graded using the aspects, a quantitative scoring system that gives points for 10 different MCA territories as shown. The total aspect score ranges between 10, indicating normal CT, and 0, indicating complete MCA infarction, as it is calculated by subtracting 1.4 every ischemic region. And aspects of 7 points and below has been indicated as a predictor of poor clinical outcome. And generally, it has been used as an inclusion criterion in acute ischemic stroke and the vascular trials, which included patients with relatively small core infarct in aspect of 6 to 10. CT alone is therefore insufficient in some patients to make a decision on treatment strategy. Specifically, the 2019 guidelines for the early management of acute ischemic stroke recommend CTA with CTP or MRA with diffusion MRI, with or without MR perfusion for certain patients. Next step after CT should be CTA for detecting large vessel occlusion, as poor recanalization rates with IV thrombolytic therapy alone has been reported in the presence of large vessel occlusion, and CTA is useful in detecting eligible patients for mechanical thrombectomy. Importantly, recent evidence suggests that imaging with CTA is not associated with increased risk of acute kidney injury in patients with stroke, and even in those who are known to have chronic nephropathies. Therefore, treatment should not be delayed to obtain creatinine levels prior to CTA due to concerns regarding contrast-induced nephropathy in patients with acute ischemic stroke. In patients who present within the first 6 hours of the onset of symptoms, particularly the gradient echo sequences of MRI can be as exact as CT in identifying hyperacute intracerebral hemorrhage. Moreover, based on the evidence showing that patients with abnormal diffusion MRI and normal flare imagings are likely within the first 3 to 4 hours of stroke onset, and MRI can be used to estimate the onset of ischemic incident. Now, the case time, our patient, a 72-year-old female who was admitted to our hospital within the first 2 hours of left-sided hemiparesia, and the CAT scan was unremarkable and ruled out the presence of intracerebral hemorrhage, figure A. And figure B, there's a diffusion MRI and hyperintensity is shown, and low signal intensity on ADC and normal flare, and the thrombus and the right side, right MCA was visible on CTA. The DAWN and DIFFUSE trials have pointed to the benefit of mechanical thrombectomy in stroke patients who present beyond the accepted time limits and who are selected based on specific criteria on CT or MRP studies. Accordingly, CTA with CTP or MRA with diffusion MRI with or without MRP are recommended for selecting patients with large vessel occlusion for mechanical thrombectomy within 6 to 24 hours of last known well. Now the reperfusion therapies. Since the first publication of guidelines for acute ischemic stroke, many changes in the evidence-based treatment recommendations have been made and included into the American Heart Association and American Stroke Association-based updates. For many years, the administration of tissue plasminogen activator alteplase has been the gold standard treatment. And since the benefit of therapy is time-dependent, treatment should not delay for additional neuroimaging and should be initiated urgently. And a recent meta-analysis evaluating the association of cerebral microbleeds and the risk of ICH after IV alteplase treatment showed that ICH is more common in patients with baseline cerebral microbleeds. Now, contraindications for medical thrombolysis with IV alteplases are as shown. And other intravenous fibrinolytics, and tenecteplase, a genetically modified variant of alteplase with greater fibrin specificity, demonstrated lower hemorrhagic complications in previous trials of acute myocardial infarction, but better functional outcomes were achieved with IV tenecteplase. Although there are studies regarding IV streptokinase or desmoteplase usage, no difference in functional outcomes was observed after the administration of IV streptokinase within 6 hours or desmoteplase within 3 to 9 hours after acute ischemic stroke compared to placebo-treated patients. For years, IV alteplase has been the treatment of choice in acute ischemic stroke patients. However, it has limitations such as narrow therapeutics, time window, and contraindications. So, mechanical thrombectomy was initially proposed as an adjunctive therapy for IVT. However, randomized controlled trials have proven the superiority of mechanical thrombectomy over standard medical management alone after acute ischemic stroke due to large vessel occlusion. The aim of mechanical thrombectomy is to achieve recanalization and reperfusion. Therefore, door-to-grain puncture time is highly important. Since trials have revealed that disability outcomes are directly associated with the time from symptom onset to arterial puncture, any cause for delay to mechanical thrombectomy, like observing for a clinical response after IVT, should therefore be avoided. Importantly, in 2019 guideline, pretreatment with IV alteplase recommendation has been removed. And the advances in device technology have significantly improved the speed and efficacy of recanalization. Here we see some of the randomized controlled trials on mechanical thrombectomy and general standard of care. So, blood pressure management. Low blood pressure levels may cause loss of penumbra, and high blood pressure levels may increase the risk of intracranial hemorrhage. So what should optimal blood pressure range be? Guideline has recommended the maintenance of blood pressure levels below 185/110 in patients who will receive reperfusion therapies either with IVT or mechanical thrombectomy. On the other side, in patients with blood pressure over 220/120 who will not undergo IV alteplase or mechanical thrombectomy and have no comorbid conditions requiring acute antihypertensive treatment. Lowering blood pressure by 15% during the first 24 hours after the onset of acute ischemic stroke is recommended. And recommended first-line antihypertensive drugs are labetalol, nicardipine, and clevidipine, and alternatively nitroprusside and hydrolazine and enalaprolate can be considered for selected patients. Including decreased reperfusion rates, infarct expansion, poor neurological recovery, and death, hyperglycemia is commonly targeted during the management of acute ischemic stroke. So hypo or hyperglycemia should be avoided and treated accordingly in patients with acute ischemic stroke. And for body temperature management, avoidance from both hypo and hyperthermia, maintaining normothermia are recommended. And hypoxia is an important cause of injury during acute ischemic stroke, and although oxygen supplement seems a reasonable approach to prevent hypoxia and supply penumbra oxygenation, and excessive oxygen may cause respiratory compromise and vasoconstriction, therefore leading to worse outcome. On the other hand, hyperoxygenation was not associated with either increased complication rates or better neurological outcomes after acute ischemic stroke. And current guidelines recommend close monitoring of acute ischemic stroke patients to keep oxygen saturation above 94%, and routine oxygen supplementation is therefore not recommended in cases with oxygen saturation above or equal to 94% spontaneously. Hyperbaric oxygen therapy is only recommended exclusively for strokes due to air emboli. Seizures after stroke occur in a wide range, and currently there are no evidence-based guidelines available regarding the prophylaxis or medical management of post-stroke early seizures, late seizures, and post-stroke epilepsy. And besides, treating all recurrent seizures with an anti-epileptic drug, regardless of the etiology, is recommended. And current guideline for anticoagulation, current guidelines recommend the administration of aspirin within the first 24 to 48 hours of acute ischemic stroke, and administering alternative antiplatelet agents in patients with the contraindications to aspirin. In addition, administration of dual antiplatelet therapy with aspirin and clopidogrel started within 24 hours after acute ischemic stroke. Onset is recommended for patients who present with a non-cardioembolic acute ischemic stroke with NIHSS score below equal 3 and who did not receive IVT. So how about management of cerebral edema and increased intracranial pressure? And brain swelling and edema formation after cerebral ischemia remains the major cause of death in patients with large infarctions, despite the advances in overall management of acute ischemic stroke. And patients with severe brain edema showed higher baseline scores, more often early infarct signs on admission CT, greater hypodensity volume, and higher frequency of symptomatic hemorrhagic transformation on the follow-up CT, higher mortality. As expected, particularly younger patients are more prone to neurological worsening due to fatal brain edema than older patients who have cerebral atrophy. So the initial general management of increased intracranial pressure after acute ischemic stroke includes elevation of the head end of the bed in an attempt to improve venous drainage. Additionally, factors that increase intracranial pressure such as hypoxia, hypercapnia, hyperthermia, hyperglycemia, and antihypertensive drugs, particularly those that can cause cerebral vasodilatation, should be avoided. And current guidelines aiming at reducing cerebral edema and intracranial pressure in stroke patients recommend the use of osmotic therapy with mannitol or hypertonic saline for patients with clinical deterioration from brain swelling associated with cerebral infarction. Today, hyperventilation is not recommended as well, and except for brief periods of moderate hyperventilation for patients with acute neurological deterioration due to brain swelling prior to a more definitive therapy. So how about emerging new treatment strategies? For stem cell, more research is needed, and for transcranial MRI-guided high-intensity focused ultrasound, thrombolysis is a new technology that is still evolving, and the larger scale of patient-based clinical studies is needed. So, conclusion, ischemic stroke is a life-threatening disorder requiring accurate and rapid diagnosis followed by proper management, and both the management and prevention strategies have undergone considerable modifications during recent years, and utilization of endovascular techniques and extension of therapeutic time window are probably the most exciting advances in acute ischemic stroke. And provision of adequate reflection of these advances to the field requires a multidisciplinary team approach in stroke care, including pre-hospital healthcare providers, emergency medicine physicians, neurologists, neurosurgeons, and anesthesiologists and radiologists. A current knowledge regarding acute ischemic stroke underlines the prominence of appropriate application of available treatments in achieving favorable outcomes of patients with acute ischemic stroke. On this regard, barriers to achieving effective pre-hospital and in-hospital stroke care, as well as care during post-stroke recovery, should be considered in low and middle-income countries, thereby proposing alternative strategies which have applicability in these areas. Thank you very much.
Thank you so much, Dr. Ocak. Is there any questions? So, thank you, Doctor. And I want to invite for last speech, Dr. Bruno Megarbain from Paris, France, to talk about management of cardiotoxicated patients and indications for ECMO.
Okay. So, good afternoon, everybody. I would like first to thank the organizers for having invited me to talk about poisonings. I'm very pleased to be with you, and we'll discuss the management of cardiotoxic poisonings and see what are the indications of ECMO. I have no conflict of interest. So, as you may know, cardiotoxic poisonings are relatively rare. They represent, based on the data from the American Poison Control Centers, the 7th cause of exposures, but unfortunately the 2nd cause of deaths. Of course, by cardiotoxicant, we do not only mean cardiovascular pharmaceutical drugs, but also different compounds able to intoxicate the heart. One important issue with cardiotoxicant is the ingested dose. You see here there is a quite good parallelism between the ingested dose of ajmalin and the resulting toxicity with the onset of cardiac arrest. So the inter-individual variability with cardiotoxicant is very limited, in contrast, of course, to psychotropic drugs. So what is the strategy to manage cardiovascular failure related to drugs? First of all, you have to establish the shock. This is not so obvious because all these drugs are able to reduce the blood pressure, which is their function, but that does not mean that the patient is in shock. Then you have to determine the mechanism of the shock, to define the optimal treatment, and in some very selected cases, to discuss if the shock is refractory to conventional therapies, some exceptional treatments. So, how to establish that the patient is in shock? You have to use the same definitions as in the septic shock, for instance. So you have to rely on the reduction in blood pressure, but also you have to identify some impairment at the microcirculation, meaning that you have to use clinical and physical examination, but also ask for some biomarkers, including lactate. You have to be aware that blood lactate concentration is not a good indicator of organ failure with beta blocker poisoning. You see here on that slide that almost half of our beta blocker poison patients who died effectively have normal lactate concentrations at any time of their management, despite the severity of poisoning. Because, of course, beta blockers will block the production of lactate. Once you establish the shock, you have, of course, to determine its mechanism. Is it a cardiogenic shock, a vasoplegic shock? So you have to measure the cardiac index, and you have to use the devices that you are used to. Of course, echocardiography should be one major device. When you normalize the preload parameters, then you can measure the cardiac index and differentiate peripheral versus cardiogenic failure. Then once you have determined the mechanism, you have to go to conventional supportive therapy. Of course, you will provide fluids, adequate catecholamines in case of ventricular tachycardia or fibrillation. You have, of course, to defibrillate. You have to infuse magnesium and rapidly, if required, you have to intubate and mechanically ventilate the patients, although the indication of tracheal intubation is not based on this Glasgow coma score only, but on the severity of collapse. Of course, as in any poisoning, you have to discuss GI decontamination. Unfortunately, majority of the patients will come to the emergency department or to the ICU more than 2 hours after the exposure. So activated charcoal and gastric lavage have limited interest. Although there are increasing number of low sustained formulations of cardiotoxicants. So you can repeat activated charcoal, especially in the ICU when the patient is intubated. Hemodialysis has also limited interest because all the cardiotoxicants have elevated protein binding rates, and high distribution volumes. So you cannot remove them by hemodialysis. So rapidly, once you administer the usual supportive care, you have to discuss antidotes. That is the specific aspect of poisoning management. For beta blockers, you have to discuss in that order. First, dobutamine or isoprenaline. Then, if failing, you go to glucagon or high-dose insulin. And then you go to epinephrine and discuss ECMO if required. For calcium channel blocker, you have first to discuss calcium chloride or any calcium salts by intravenous route, then rapidly go to high-dose insulin. You see that the doses of insulin are very elevated, 1 unit per kilo IV bolus, followed by 1 to 10 unit per kilo per hour infusion. So, of course, you have not to be afraid because you know that calcium channel blockers will induce an hyperglycemia because there is a reduction in insulin production by the pancreas. Then you go to vasopressors, epinephrine or norepinephrine, and you may try methylene blue in the most severe cases of vasoplasia. For sodium channel blocker poisonings, first infuse sodium bicarbonate in case of enlargement of QRS, and then go to epinephrine. For cardioglycoside, which is now only represented by toxin, try first atropine in case of bradycardia, and then move rapidly to antidigoxin FAB fragments. So these are the conventional treatments. Of course, as you may see, you require sometimes some advices from a clinical toxicologist. But in some cases, the patient situation will be refractory to all these therapies. And you have to discuss exceptional treatments, and I enumerated 3 kinds of treatment: lipid emulsion, veno-arterial ECMO, and albumin dialysis. So first, let's discuss about lipid emulsion. By analogy to the management of anesthetic, of local anesthetic overdose in the operating room, you can infuse lipid emulsion that will, as a lipid sink, alterate the tissue distribution of the toxicant. But this is only hypothetical. The evidence is relatively low quality. Anyway, the advantage of this treatment is its easiness, and you have just to infuse intralipid with the dose regimen written on the slide. However, as you may know, the American and European guidelines about lipid emulsion are neutral. The specialist cannot recommend you to give intralipid and cannot not recommend you to give intralipid. So it's only your advice, your opinion. Anyway, do not administer intralipid rapidly, just in patients who fail to respond to conventional therapies, because you may decrease the exact effect of the usual treatments if you administer the lipid emulsion too early. So only give it when immediate threat to life exists, when other therapies have proven ineffective, or maybe while waiting for ECMO implementation. Because probably the good alternative for this refractoriness situation is ECMO. So what is ECMO? I mean, of course, veno-arterial ECMO is a device that may take over heart function until recovery can occur by minimizing myocardial work, improving organ oxygenation and vascularization, and of course maintaining the liver metabolism and the renal and biliary elimination of the toxicant. So of course there are several mistakes or risks. The first one is to implement ECMO too late while the patient presents already multi-organ failure or anoxic brain injury. The other risk is to implement ECMO too early, while probably if you have taken an advice from a clinical toxicologist, you may have used antidotes with adequate dose regimens, and that could have allowed you not to implement the ECMO. So there are in practical two possibilities, either to transfer immediately the patient to the surgery department or to call for an ECMO team and to implement the ECMO on site. In our ICU, which is specialized in toxicology, but in our hospital devoid of cardiac surgery, we developed